All right, chapter 22 is going to be immunologic emergency, immunology, recognition and management of shock and difficulty breathing related to anaphylactic reactions and allergic and anaphylactic reactions. So, allergy-related emergencies can involve acute airway obstruction and also can cause cardiovascular collapse. So, the allergic reaction is an exaggerated immune response to any substance that may require epinephrine or anaphylaxis. Anaphylaxis is the extreme systemic form of an allergic reaction involving two or more body systems. So distinguishing between the body's usual response to an allergen, and an allergic reaction. The immune system helps protect the body from substances and organisms that are considered foreign to the body. Without the immune system, a body would go under constant attack from any bacteria, virus, or other invader that wanted to make our bodies their home. The body protects cellular immunity. The body produces specialized white blood cells called T cells that attack and destroy invaders. Humoral immunity. The B cell lymphocytes produce antibodies that dissolve in the plasma and lymph to wage war on invading organisms. Cell-producing immunity factors intercept foreign invaders as they enter the body, and given the right person and the right circumstances, almost any substance can trigger the body's immune system and cause an allergic reaction. So such things as animal bites, food, latex gloves can all be allergens. 5 general categories of allergens: insect bites and stings. When an insect bites a person and injects the bite with venom, it's called an envenomation or a sting. So medication, the reaction of an injected medication may be immediate or severe, and reactions to oral medications may be slower but can also be severe. Plants, people who inhale dust, pollen, mold, mildew, or other organic materials to which they are sensitive may experience an allergic reaction. Foods, when consuming certain foods such as shellfish and peanuts, may result in a relatively slow, more than 30 minutes reaction, but may still be quite severe. Certain chemicals make up soap, hair dye, latex, and other substances can cause severe reactions also. Allergens are usually harmless. The antibody or protein produced by the body in response to an antigen. There's a table with some common antibodies, their reactions, and locations. Some foreign substances invade the body through the skin, respiratory tract, or the gastrointestinal tract. Invasion through the skin may come in the form of an injection. Invading substances pierce the skin and deposits foreign material into the skin. Absorption. Foreign material is deposited on the skin and slowly absorbed through the skin. Invasion by allergens may enter the respiratory tract, have the patient breathe. And the final way allergens attack the body is through the gastrointestinal tract via ingestion. All right, biology review. When a foreign substance invades the body goes on alert and initiates a series of responses. The first encounter begins with the primary response, mainly involves the white blood cells. Macrophages immediately greet, confront, and engulf invaders. So they determine if they are allowed in the body. These macrophages do. If the body is unable to identify an invader, the immune cells are used to record the features of the substance. The immune cells design proteins to match each substance. The antibodies match up with the antigen and inactivate it. The body then develops a sensitivity through the primary response, the ability to recognize the foreigner next time it is encountered. The body places specific antibodies on basophils stationed in specific sites within tissues, mast cells on patrol throughout the connective tissues, bronchi, gastrointestinal, mucosa, and other vulnerable border areas. Chemical mediators, chemical weapons produced by basophils and mast cells, to contain granules filled with powerful substances to fight invading foreign forces or antigen. Granules get ejected from mast cells and detonated if the antigen invades the body and combines with one of the antibodies. Degranulation, granules burst, releasing powerful contents. They launch and maintain the immune system and summon more white blood cells to battle the invaders. So this causes increased blood flow to the area under attack and useful when a small invasion occurs in a limited area. But however, it can be dangerous when they spread throughout the body. So when chemical mediators cause systemic effects, they cause anaphylactic reaction. So here's a picture. This figure shows the sequence of events in anaphylaxis. So in A, the antigen is introduced into the body. B, the antigen antibody reaction occurs at the surface of the mast cell. C, the mast cell chemical mediators release. D, the specific antibody reacts with the corresponding antigen. And then E, the chemical mediators exert their effects on end organs. So, vaccines produce immunity against disease. The body develops antibodies in response to the vaccine. It produces an immune response to neutralize the disease, and it develops antibodies to control away. If an actual virus enters the body afterward, the virus is identified. Antibodies are produced to kill it. And secondary response, intense response to an invading virus. In acquired immunity, administration of a vaccine allows the body to produce antibodies without having to experience the disease. In natural immunity, the body experiences the full immune response with all the effects of the disease. So, some pathophysiology, immune system becomes hypersensitive to one or more substances during an abnormal reaction. In the allergic reaction, immune system reaction that occurs when a person has been previously exposed or sensitized to a substance or allergen. All right, in allergic reactions versus anaphylaxis. An allergic reaction is a mild and localized reaction, and it could cause a systemic reaction. Some hypersensitivity is exaggerated or inappropriate allergic reactions after coming into contact with a substance perceived by the body to be harmful. Anaphylactic events should not be mistaken for heart attack, heat stroke, or other condition. Diseases related to allergies such as allergic rhinitis, asthma, and atopic dermatitis increase the potential for anaphylactic reaction. Anaphylaxis is mediated in the IgE antibodies. Anaphylactoid reactions does not involve the IgE antibody mediation. An anaphylactoid event may occur without the patient being previously exposed to the offending agent. So, mast cells recognize the foreign substance as potentially harmful and release chemical mediators. Two types of chemical mediators. The histamine causes blood vessels in the local area to dilate and the capillaries to leak. Leukotrienes are more powerful than histamines and cause additional dilation and leaking. White blood cells are called to the area to help engulf and destroy the foreign substance. And then platelets begin to aggregate. And in most cases, the reaction is restricted to the area involved. So, in this picture here, you can kind of see a localized reaction. So, in anaphylaxis, chemical mediators are released and the effect involves more than one body system. The initial effect may be seen from release of histamine, with secondary effects following a few hours later. Histamine release causes immediate vasodilation, often presenting as flushed skin and hypotension. Increased vascular permeability resulting in angioedema. Edema presenting has urticaria, airway constriction, and increased fluids in the airway. Smooth muscle contraction, especially in the respiratory and gastrointestinal systems, which cause lyricospasms, bronchospasms, and abdominal cramping. This decreases inotropic effects of the heart. So when combined with vasodilation, profound hypertension may develop. So release of leukotriene compounds the effects of histamine. Further compromises respiratory status, coronary vasoconstriction, and worsens hyperperfusion. So the remaining chemical mediators continue to worsen the situation. All right, some clinical symptoms of anaphylaxis. Skin symptoms are often the first indications of anaphylaxis. Persons may feel warm and flushed. Itching due to vasodilation and capillary leaking. Area around the eye is susceptible to this effect. Angioedema, swelling in the hands and feet, urticaria. Respiratory symptoms are the most common complaints: shortness of breath, dizziness, tightness in the chest, throat. You'll hear that stridor and also hoarseness. All of this is due to upper airway swelling in the laryngeal and epiglottic areas. Patient may complain of like a lump in their throat also. Bronchial constriction and increased airway secretions, coughing and sneezing, and symptoms may be slow or rapid. Cardiovascular symptoms are serious complications of anaphylaxis. So you have that decrease in cardiac output. It's complicated by vasodilation and increased capillary permeability, decreased cardiac output and perfusion, increased ischemia, and potential for cardiac dysrhythmia. Tachycardia, flushed skin, and hypertension are synonyms with anaphylaxis. Blood volume moving from the intravascular space to the extravascular space can cause shock. The body will not tolerate an acute blood loss of greater than 20% blood volume. Gastrointestinal symptoms may occur, and then partial, particularly when the antigen is ingested. Abdominal cramping and also nausea, bloating, vomiting, abdominal distension, and profuse watery diarrhea may be present. Central nervous system may cause headaches, dizziness, confusion, and anxiety, and that sense of impending doom. So anaphylaxis may affect two or more bodies. So in your patient assessment, you need to do these assessments very quickly. So a suspicion for anaphylaxis may be high if any of the pertinent symptoms are present. Response to antigen may occur in a multi-step manner, with the immediate acute response being followed by a later delayed response. Reactions can be acute or delayed. Acute reactions typically result in a most life-threatening situation. Delayed reactions may take hours or longer to manifest, and the response is not usually exaggerated. In prolonged, persistent reactions, anaphylaxis symptoms continue over time for 5 to 72 hours. In a biphasic response, the patient experiences an initial reaction, appearance to be recovered, and then experiences a recurrence of symptoms. Patients who experience an allergic reaction should be encouraged to seek medical attention to minimize the effects of delayed reactions. So consider the safety, patient's environment, or recent activity may indicate the source of the reaction. A respiratory problem reported by dispatch may be an allergic reaction. Never enter a scene when more than one person is experiencing the same symptoms with a similar onset. Consider the need for additional or specialized resources, such as hazmat resources. In your primary survey, severity of the problem will indicate by the patient's presentation. Immediately begin the airway evaluation and management. Respiratory symptoms should be swiftly assessed, and noisy upper airway may be an early sign of impending airway occlusion. Begin basic life support measures in an unresponsive and pulseless patient. Assess for signs of shock. Treatments for shock should include administering oxygen, placing the patient supine, preventing the loss of body heat, and definitive treatment of shock resulting from anaphylaxis is epinephrine. So investigate the complaint and history of the illness, identify the signs and symptoms, obtain your sample history, check if any interventions have already been completed, check if the patient has experienced a severe reaction in the past, and ask about previous exposures to common allergies. So the one thing you want to ask about interventions already completed is that there are EpiPens out and about in lay people's hands, and a lot of these patients have EpiPens prescribed to them. One thing you need to make sure you check on is make sure that EpiPen is possibly in date, and please make sure that it is the patient's EpiPen. I know that some schools and some public facilities do have EpiPens available, along like the AEDs are available. However, you need to make sure that they're being given correctly. In your secondary assessment, perform a physical examination. If the patient is experiencing life-threatening signs and symptoms, perform the route to the hospital. Auscultate for abnormal breath sounds. Inspect the skin for the source of the reaction. So you want to ask. A lot of times these patients can tell you where they've been bitten at, or how the foreign body enters their body. They'll be able to tell you pretty quick. So rapidly spreading rash may indicate a systemic reaction. Red hot skin is typically an early stage, suggesting a systemic reaction. Systemic reaction alters mental status. Your vital signs help determine whether the body is compensating for stress. Assess baseline vital signs, including pulse, respiration, blood pressure, skin, pupils, and oxygen saturation on room air. Cardiac monitoring may determine dysrhythmia associated with anaphylaxis. Monitored by pulse oximetry may alert you to low oxygen saturation. Also, don't forget about your end titles. They are more reliable than pulse ox in low perfusion state. So the decision to administer oxygen to a patient experiencing an allergic reaction should be based on a careful assessment of the patient's airway and breathing, and not solely on pulse ox readings. So, 9 out of 10 times with these patients, they are going to get that non-rebreather initially to boost up their oxygen saturation, because there is a invasion of the basically the whole systemic respiratory system itself. You may decrease that later. You may have to give other medications to help with wheezing. The respiratory system itself goes through a lot of trauma and anaphylaxis. As long as you are able to treat it early, you should be okay. So when you're reassessing these patients, conduct typically en route to the hospital. Special attention to be given to any signs of airway compromise. Monitor the patient's anxiety and mental levels. Watch for signs of shock and treat immediately, and identify the severity of the reaction. So interventions check the effect of epinephrine administration. This is going to be your AP1 to 1000. Hopefully given IEM. So check if the patient's condition has improved or if the second dose is required, and then recheck your intervention. All right. So when to contact medical control does depend on your findings. In some allergic reactions, you may use standing orders and administer epinephrine. For less severe reactions, contact medical control. Documentation includes signs and symptoms and explain why you chose to provide the care you did. Ensure to record the patient's response to the treatment. Essential in emergency medical care, it is essential to differentiate between anaphylaxis and other conditions with similar symptoms. So people with allergic reactions are separated into two groups. The first group is the patients who have signs of an allergic reaction but no signs of anaphylaxis. The second group is patients with signs of anaphylaxis who require 100% O2, epinephrine, and antihistamine. So whenever dizziness or signs of shock are present with signs of an allergic reaction, you should administer epinephrine. Closely monitor the patient and provide rapid transport. This first group of patients, they're going to be itching with no respiratory Compromise, they're going to be talking to you, be able to speak in complete sentences. O2 saturation should be, 94 to 100%. So, you may be able to just give an antihistamine such as Benadryl to these patients. However, be on alert for that to turn into an anaphylactic reaction any time. Okay, the anaphylaxis patients always will be respiratory compromised. That airway swelling, I can't breathe, that hoarseness, that stridor. That's where you're going to have to give these patients epinephrine, 1 to 1,000, 0.3 to 0.5 for the adult patients. And if they're above 50, give a half of 0.15, and also your pediatrics of 0.15 to 0.3 at the max. Don't be scared to administer your medications. This is what's going to help these patients. A lot of these true anaphylactic shock patients, they're kind of like the hypoglycemic patients, the ones that you can fix out in pre-hospital conditions. It kind of help you, be like, cool, I've made a change today. The early administration of epinephrine should be priority. Use the IM route if the patient has evidence of airway compromise or hypotension. Administering the thigh is preferred over the deltoid site for more rapid absorption. Subcutaneous administration of epinephrine is unpredictable and may have a delayed effect in the presence of shock. Epinephrine can rapidly reverse the histamine-related effects of anaphylaxis. So many patients in EMTs carry epinephrine in the form of the EpiPen. Patients who receive epinephrine must be monitored closely for adverse effects. Direct order from medical control required to help a patient with an auto-injector. Okay? If a life-threatening situation, do not delay administration of epinephrine to expose the thigh. An EpiPen can be administered directly through the plasma. Injection time is 3 seconds. Take steps to ensure the patient's leg does not move during administration. Properly exposing the injector after administration in the biohazard container. If there is no improvement, 5 minutes, administer second dose. Other allergy kits may contain oral antihistamine. Epinephrine and antihistamines work together. Some side effects of epinephrine: tachycardia, hypertension, anxiety, calor, dizziness, chest pain, headache, nausea, vomiting. Patients who do not exhibit signs of respiratory compromise or hypertension and do not meet the criteria for a diagnosis of anaphylaxis should not be given epinephrine. Provide prompt transport for any patient who has experienced an allergic reaction or who has experienced poisonous envenomation or a bite. So continue to reassess these patients. Vital signs and route. Consider early transport if the patient needs resources beyond your capability. Some ants, especially fire ants, strike repeatedly, injecting a particular irritation, toxin, or poison at the bite site. Some patients will be fine with this. Some patients will have a reaction, a true reaction to it. So signs and symptoms of allergic reactions: sudden pain, swelling, localized heat, widespread urticaria or itching, and redness. And they may be itching and sometimes a well. So that's a raised, swollen, well-defined area on the skin. Applying ice sometimes make the wells less irritating. Attempt to remove the sting by scraping the skin with the edge of a sharp, stiff object such as a credit card. Do not use tweezers or forceps. Squeezing may cause the stinger to eject more venom into the wound. Once the stinger is removed, wash the area with soap and water and a mild antiseptic. Try to remove jewelry from the area before swelling begins. Position the injection slightly below the level of the heart and apply ice or cold packs to the area. Be alert for signs of swelling and signs of anaphylaxis. Place the patient in a supine position if indicated and give oxygen if needed. Monitor the patient's vital signs. Be prepared for additional support. The best management of anaphylaxis or allergic reactions is to educate patients in prevention and self-preservation. Avoid the antigens and notify all health personnel of the allergy. Wear identification tags or bracelets. Carry anaphylaxis kit or EpiPen and report symptoms early. So just be very careful with these patients after you have to give them epinephrine. Some side thoughts you may cause a cardiac event also, so please recheck 12 leads post giving these patients epi. The wheezing, the respiratory compromise may not go away immediately, so bronchodilators may need to be used also, and which may lead to respiratory steroids that you may need to give. So, you at the advanced EMT level may need to also call medic out of these situations to kind of make sure that they don't need any further medications that you can't give at your level. So that's the end of this chapter. But like I said, allergic reactions and anaphylaxis is one of those situations that we can fix in the pre-hospital environment. However, these patients do need to be further evaluated at a facility for the long-term effects of these drugs that may have to be given. Management of insect stings account for approximately 90 to 100 deaths each year in the United States. The stinging organ of most bees, wasps, and hornets is small, hollow spines projecting from the abdomen.